Thank you, Chairperson. And at the outset, thank you, Dr. Bansi Sabu, sir, as well as the team Diabetes India for inviting me and giving this topic. It's extremely important topic, but very common topic as well. I think in this particular room, probably all will agree that we all are using some kind of point of care testing in our diabetic clinics. So it definitely is the right tool to meet, and that is what I'm going to decode. So first and foremost, obviously, we are really concerned about diabetes. It's becoming a growing health concern worldwide, and it's extremely important we really effectively diagnose diabetes. Timely intervention is important, and proper management is has to be accurate as well. So POCT has emerged as a valuable tool in diabetes management. How do we really define point of care testing? Is any medical diagnostic testing which is near the site of the patient care. So it can be at a home as well. That is also known as POCT, also at the office. So it usually involves a portable device which to analyze the biological samples, be it blood or urine, or to diagnose and monitor the medical conditions. So point of care instrument probably is today in today's world probably is a very important tool whenever you are planning out a management tool for our patient. So what does why do we really need POCT? There are various benefits. You can timely diagnose the case, timely intervene, depending upon the specifics of that particular the POCT machine, and then improve the glycemic control and reduce the complication, and thereby obviously you can enhance the patient's satisfaction and engagement. Ultimately, in spite of the initial incremental cost, you probably will be able to reduce the overall cost of complications. So what are the POCT devices which we use in today's world in India in most of the diabetic clinics? These are the blood glucose monitor, the HbA1c analyzers, the urine albumin ketones test, and the lipid profile analyzer. We have few others as well, but probably these are the commonest one which we use in our diabetic clinic. So why then we have to impress upon POCT? We have numerous reasons for that, but then we have to compare with the traditional testing as well. POCT facilitates the real-time decisions. What we have in traditional tests is you give a sample, you are expecting the results sometime in the evening. Accuracy, obviously, you might have to compromise a little bit on accuracy, but if you do a proper validation and if you can realize that what is the level of accuracy which you need to intervene with the traditional testing, probably you can come out with accurate kind of reports. Cost per test cost may be high in comparison to the traditional test, but then it enables a quicker kind of your results, and thereby you can intervene quickly. Accessibility, it is as it is performed at the point of care, so it becomes much more accessible. Technological integration is practically possible with the POCT vis-a-vis the traditional method. So that is another area which probably will need much more improvement, which I'm going to come later. And as far as the patient experience goes, it definitely reduces the need for multiple visits if they can do a POCT then and there at the office or at the home and come out with the results. You can plan out the therapy, and obviously that will help us impact the experience of the individual. And POCT is definitely limited to specific tests only. You cannot do the gamut of tests which can be done by traditional testing. So this is a difference basically. Why I want to bring this particular important aspect at POCT in pregnancy. Now probably any pregnant lady who is either diagnosed with diabetes or is diagnosed with GDM for a pre-diabetes probably should have a point of care machine, because that is how she can monitor and modify and get the best outcome out of it. So introduction to POCT in antenatal care is extremely important. It plays a crucial role in monitoring and managing conditions thereafter. So importance of rapid glucose assessment to make immediate clinical decisions. Improvement in maternal outcome is definitely because you can monitor, you can modify your management, and thereby can prevent the complication during delivery or during the postpartum period. Then you have, along with that, enhancement of the neonatal outcome as well. So you have a better kind of glucose control, you have a better kind of profile, then obviously the neonatal complications can be prevented. We can prevent macrosomia, neonatal hypoglycemia, the complications as well. You can empower through the patient education. See, the most receptive time life in the life is probably at the time of pregnancy. The patient is very receptive. If you can really introduce this point of care machine to them, then probably they will be carrying on with these kind of testing later in the life as well, and thereby can have a better metabolic health. Then streamlining the clinical workflow, incorporating the antenatal care, you can streamline clinical workflows, reduce the wait time for results, and enhance the overall patient satisfaction. And the future direction, obviously, when you can integrate that with the technology, which will definitely further improve the management of GDM or diabetes during pregnancy, diabetes in pregnancy. So, but there has certain advantages and disadvantages also are there, particularly with HbA1c POC. Now, the advantage, as we all are aware of the fact, you have a machine at the office. The patient does not come out with his HbA1c level. You immediately do it. You get a rough idea about what the HbA1c is. Rather, there is hardly about 0.2% difference between the POC, which is validated POC at office, and which you will do with venous blood. Then at single visit, you can get it done. It is definitely convenient because this is a finger stick specimen, and it is waived in US. Trained laboratory personnel not required. And then along with that, potential for broader reach to the low access population, glycemic outcomes on average can also be there. Disadvantage, obviously, the waiving aspect is always like it's not standardized. It is different at different global parts. Less accurate than laboratory testing. Testing cost is higher than those, which I don't agree. Probably now the testing cost is much lesser, even with the comparison to the traditional one. Interference will always be there, whether it's with traditional or with the POC machine. Accuracy concerns will always remain. See, accuracy concerns always depend on the methodology which you employ, how well you actually follow the dictum of that machine. That's very important. They have a very specific protocol that need to be followed to the T in order to get the best of the accuracy. Now, what is the future of POC? Now, exploring the next generation of diagnostic solution, one need to understand that AI-powered smart POT devices are coming up, which will be revolutionizing the diagnostics. These smart devices are capable of analyzing the patient data in real time, providing faster and more accurate results. For instance, the AI algorithms can interpret complex test outcome, reducing the chance of human error, enhancing the decision making in the for the healthcare providers. Then you have the wearable integration. You can always integrate the POC results with the wearable technology, which probably are coming up day in and day out, and they will definitely enable will have a proactive healthcare management for the individual and also for the healthcare providers. Then you have the non-invasive glucose monitoring. We had a big talk on CGM. A debate was going on and all. Now, the development of non-invasive glucose monitoring technique requires a significant advancement in diabetes management, but the POC has an important role to play, because what happens at times, these CGM machines can be a little bit of problematic. You can always try to validate that against the POC machine which is available at your office. So that again is going to be a easy tool, at least, to rule out any kind of fallacies. Now, now we are probably living in telemedicine or virtual care, and we have been thought about it during the COVID time. So there is definitely a role of POCT in telemedicine, which can allow for real-time monitoring and management diabetes from the comfort of the patient's home. You can always plan out the management. You can dictate the management. You can also oversee how the patient is behaving. Then it is definitely a benefit for rural population. We have the outreach clinics, we have the district clinics, para clinics, and all those clinics which can actually, with the technology, it can be the results can be approached, and thereafter we can give the right kind of management which is required for that individual. And integration of the home-based POCT device in diabetes care allows the more personalized management strategies, which will definitely lead to timely intervention and best outcome for that individual. Now, POCT and already said you have to explore the synergy between these two technology. You integrate them and become a valuable complement to both of them. So that is very important. You also support for CGM calibration. I've already spoken about that. It can support the calibration of CGM devices. So they are the accurate calibration will help us to be more reliable and precise, effective for effective diabetes management, basically. Enhancing the glucose variability assessment, and very important aspect, POCT provides additional data. CGM gives you an idea of the very glycemic variability. So do the glucometers as well. And if you combine both of them alongside CGM, POCT is then you have the most appropriate kind of assessing whether the patient is having glycemic variability, and more comprehensive you can see, and then better tailored program can be set up for that individual. So digital health technologies and POCT, this is another one. Obviously, these health technologies can definitely improve POCT and improve the patient outcome. Integrating this POCT with the health technologies can facilitate more effective diabetes management. We have lots of them, mobile apps and telehealth platforms. And one of the pioneers is sitting out here. I don't want to speak too much on that, Rakesh. And therefore, obviously, that is definitely going to help us. And this is the future. Let me tell you that we have to combine this digital health technology and the POCT. Artificial intelligence and machine learning are the way forward. Enough of I think symposia were there on these two, and they will definitely have the potential to revolutionize the POCT and improve the patient outcome. And just applying those at all to the POCT data will facilitate more effective diabetes management. But in spite of everything, we have the challenges and the limitations. Cost and resource allocation will be an issue, which can always be a problem when we talk of any new devices, of any kind of stuff. But then it can be taken care of with appropriate usage of your resources. Training, education of healthcare professionals. I told you the accuracy of an instrument totally depends on the way you use it. You need to follow the protocol to the best so that you can get the best outcome. Quality assurance has to be there, and then integration with the electronic health record is a must. Probably all of us are practicing maintaining electronic health records, and then we'll definitely be able to have an effective implementation of POCT. So quality control and assurance in POCT, you have to ensure it. You have to be ensuring the quality so that you can rely on the test results, implement the quality control processes, you train the healthcare professionals who are working with you, and then regularly evaluate the POCT performance as well. The most common problem which we face, probably you are not even looking into that, is the battery life of the machine. So once you are aware of the fact that when do you really need to replace that battery, that's very important. Then you can always have a better results. So ensure training on top, implement calibration procedures, establish quality control measures, monitor performance and outcomes, engage in continuous education. So these are paramount in order to make the POCT machine, POCT effective. But then you have to have standardized practices. Ensure POCT accuracy and reliability. You have to have a local body approvals. You have to have some of the devices need to have FDA approvals. Then you have the waivers which should come into, and then you have the ISO guidelines which should be followed up. Cost benefit analysis is extremely important. So that has to be taken into consideration. You need to look into the long term the healthcare cost. So however well you can lower that cost, that will definitely be good. You have to improve the patient outcome, accessibility of testing, and then you have to have the support for the healthcare providers as well. So POCT is a cost-effective option for diabetes management. Also, the guidelines have supported using POCT in diabetes management. And let me finish with these three such papers which has come recently, one by our own Bansi Bhai. He has recommendations for the in-clinic POCT for diabetes management in India. You should read the paper. It is there. Then you have this point of care testing by Michael, which probably again is a pointer to the fact that POCT is of importance in our clinics. And then the way forward, I already said, application of AI and ML algorithm extremely important, and development of new POCT devices and technologies probably will give us much more confidence in using them, and thereby can overcome the barriers associated with the POCT. But implementation strategy should be very simple. You should be able to it requires careful planning and execution, and must access the readiness, develop a business case, and select the POCD device and vendors. Not that what they have been propagating here. You can use all of them, not necessarily as per your patient's outlook. You probably need the right kind of POCT for that. So concluding, the point of care testing provides immediate results, enabling healthcare professionals to make timely decisions in diabetes management. This quick turnabout can lead to faster treatment, adjustment, and improved patient care. It definitely reduces complication because you are able to intervene quickly and improve the parameters. The proactive approach can definitely decrease the risk of severe health issues associated with diabetes, improves the patient outcome, and then only concern obviously remains the accuracy and quality control. Thank you, sir.
Thank you, Dr. Bijay.
Absolutely, in body scan. He's talking about is a costly machine. Basically, what I'm saying, according to your patient's outlook, I think whichever kind of wherever you're working, it depends upon that atmosphere or environment where you can plan out which is the right appropriate POCT for that clinic. Thank you.
Thank you.
Thank
We
you,
are
sir.
running short of time.
Thank you,
We
sir.
are moving to next topic. That is metabolic syndrome and erectile dysfunction. We invite our speaker, Dr. Bobby K. Matthew. He has done his MBBS MD from Government Medical College Trivandrum, DM Endocrinology from KEM Hospital, and is working in Wellcare Hospital Cochin and NMC Hospital Sarja. His interested topics in andrology, thyroid, pubertal, and endocrinology. Over to Dr.
Welcome. Start. Okay. Hi everyone, and this is a talk on metabolic syndrome, erectile dysfunction. Don't look at it. So, what's the definition of erectile dysfunction? Harrison tells us that it's an inability to attain and/or to maintain an erection of sufficient rigidity and duration so as to get a satisfactory sexual intercourse. This teaches if a person is not able to attain an erection, that is ED. If a person is able to attain an erection but not able to maintain the erection, that is also ED. A person is able to attain an erection, maintain the erection, but not the sufficient rigidity that his partner wants for a sexual intercourse, that is also erectile dysfunction. A person is able to attain an erection, maintain an erection, that too of the sufficient rigidity, but his partner doesn't get a satisfaction out of the sexual act, then also the purpose of erection is failed. That is known as ED or SD. When we all used to study for MBBS MD, ED was called as nothing but impotency. Open Harrison till 16th edition, second volume, second chapter used to be always on impotent men or impotency. Now by the NH revised guidelines 1992, the term impotency itself is deleted from all the textbooks because addressing a male as an impotent guy, this guy is an impotency or transgender, whatever, is thought to be great insult to manhood, because men can have decreased libido, and the most common sexual problem in men less than 45 years is not ED, it is actually premature ejaculation. Age more than 45 years, the predominant problem is erectile dysfunction. So basically ED is no longer impotency, so and ED is no longer erectile dysfunction, it is endothelial dysfunction. And what's the biggest risk factor? Massachusetts male aging study, that's why I told you I've taken everything from Harrison, just teach and finish. Only 10% of men less than 45 years have organic ED. That is age 30, 40 years. Someone comes and tells in the OPD of an endo and uro that I'm having ED. 1 in 10 only have organic organic, remaining 9 out of 10 are having psychogenic ED. Age more than 60 years, 50% of the people may have some sort of organic ED. Age more than 80 years, 80% may have some sort of organic ED. That never means that a guy of the age 80 or 85 years is not able to have a sexual intercourse with the partner. He may be having tumescence sufficient enough to have an intercourse with the partner, but he may not be enjoying that rigidity of the penis that he used to enjoy before the age of 45 years. So what are the stages of male sexual function? First is the stage of libido. You are seeing a lady or a guy in a whatever homosexual getting the kick of sex, you are having libido. Second is the stage of erection, where the blood pumps into the corpora and penis get into a stage of erection. So basically, first you are thinking that you want to have a sex with a lady, and now two types of erection is there. Always understand. First type of erection is known as a neurogenic erection. Your thought causing an erection. When you are in your teens, till the age of 20, 30, 45 years, the moment you see a female you want to have sex with, moment you chat with a female you want to have sex with, moment you hear the sound. In our childhood days, the only movie or whatever magazine, Filmfare or Debonair, you see the photo of a female that you want to have sex with, you have a tight erection of your penis without even touching your penis. That is thought causing an erection. That is known as a neurogenic erection. As your age increases above 40, 45, 50, even the strongest desire to have sex with a lady, the strongest desire, even hearing the sound, hearing the whatever, seeing a picture or even touching will not produce a full erection of the penis. You have to touch and caress your penis to have an erection. So thought causing an erection is a neurogenic erection. Touch causing an erection is known as a reflexogenic erection. So how does touch cause an erection? We know, we have studied in MBBS, the peripheral nerve supply of the perineum area is the pudendal nerve, S234. So you touch the pudendal nerve area, so the local reflex that it goes to the S234, from there to the parasympathetic nerve fibers causing an erection. That shows that the moment you are till the age of 30 or 45 years, your penile endothelium, erectile dysfunction is no longer known as impotency, and ED is no longer erectile dysfunction, it is just endothelial dysfunction. A person having adequate libido in the absence of stress with normal testosterone. A guy comes at the age of 30 years, is having full libido, desire to have sex with a lady, no stress at all. They are girlfriend, boyfriend for years, no stress at all. You are checking his testosterone. Testosterone is 10 nanogram per ml. A person after having adequate libido in the absence of stress with normal testosterone is not able to produce an adequate penile erection. That shows that his corporal cavernous endothelium is not able to produce nitric oxide for penile vasodilatation. So think whatever I have told. ED is no longer erectile dysfunction, it's endothelial dysfunction. When we used to study for MBBS, we know penis is made up of two groups of vascular smooth muscles, a central midline corpora spongiosa and a pair of corpora cavernosa on either side. Don't look at this, because penis is made up of just smooth muscles. This is the cross section of a corpora cavernosa. When your libido, what is occurring? Your impulses come, neurogenic erection, impulses come from the brain to the spinal cord, to the S234 segments, to the parasympathetic nerve fibers, and ultimately this is the endothelium. Endothelium produces nitric oxide. Nitric oxide is the most potent vasodilator in the body. So when you're thinking of a lady, your age is 15, 20 years. So one big businessman whom I saw day before yesterday from Dubai, because nowadays 18 days I walked there, 12 days only in Kerala. So he was coming and telling me, doctor, I am having diabetes for 15 years. I tried all tadalafil, I am taking 40 milligram, nothing is working. I am taking intracavernosal, alprostadil, pepaverin, fendolamine. He buys everything from Sudan and comes and mix it in an insulin syringe and takes everything. Still my erection is poor. I want to go for a penile processes, but two of my friends went for a penile process and they had a failure. So he's fearing, once you go for a penile process and a failure, you have no looking back, your penis is totally out. So he was telling that, doctor, when I was in my childhood, 8th standard, 10th standard, the moment I see the advertisement of Crowning Glory, where Dimple Kabadi was moving left, right, he had a tight erection of your penis without causing anything. Now, whatever he thinks or whatever libido, the penis is not at all moving. That is ED. Why it is not at all moving? Because ED is no longer erectile dysfunction, it's endothelial dysfunction. His HbA1c is 8.5, his BP is 140/90, his LDL is 132. All the Kerala Ayurveda doctors is taking LDL and smokes 3 packs of Rothmans and all the cigarettes per day, and belly is 120 centimeter. Then he can just dream of erection at the age of 5th or 10th standard, because the biggest risk factor of ED is no longer diabetes, it's abdominal obesity and metabolic syndrome. So previously during MBBS MD, we had an MCQ question. What's the biggest risk factor? Erectile dysfunction. Doctors used to answer diabetes, diabetes, diabetes. Now HbA1c never kills your penile endothelium. Studies in type 1 diabetic children have shown that you are having children with type 1 at the age of 15, 17 years, they are having poor glycemic control. You follow up them till 60, 70 years, 80% have a good penile erection, because HbA1c is alone the culprit in type 1 diabetes. They are not having metabolic syndrome per se. Whereas 35% of the guys coming with type 2 diabetes, the presenting symptom itself is an erectile dysfunction. So the biggest risk factor for ED is no longer diabetes, it is metabolic syndrome or abdominal obesity. That is why Rupin Shah from Bombay, who is considered as the father of Indian andrology, because he devised the Shah metallic process in Hinduja or just look everything. He was asked the question in 1 year back, and in Indian Institute of Science, there was a hands-on conference for penile process by the for the urologist. I was just taking on testosterone. He was asked the question, doctor, what is the mantra for immortal sex? Suppose a guy wants to have an immortal sex at the 70, 80, 90, what is the mantra? He was telling that never smoke, exercise properly, keep your abdominal girth less than 90 centimeter. If at all your cholesterol is high, take a statin, because the biggest risk factor for that's endothelial dysfunction is the same as the biggest risk factor for heart attack. That is your LDL. Second is your abdominal obesity. Third is your smoking. That's why recently there was a study published in JAMA where 45 to 55-year-old people with moderate ED were taking tadalafil 5 to 10 milligrams. So not sildenafil, tadalafil 5 to 10 milligrams. Were divided into two groups. 50% were asked to exercise properly and quit smoking and take a statin, and remaining 50% was to continue to take tadalafil in whatever dose. After 6 months of exercise and statin, 80% of people who were taking tadalafil 5 to 10 had a good erection without even taking any tadalafil tablets. That shows that ultimately it is your metabolic syndrome which kills your penis. It is not your insulin or it's not your glycemic control that's to save your penis. That's why the lead order in JAMA was asked a question, sir, what will you assess or what will you advise your middle-aged patients who have erectile dysfunction in the initial stage? He was asked the question, properly, never smoke, and always take a statin. Whenever possible, LDL is more than 70, take a statin. Statins and LDL. LDL ultimately kills the penis. Some guys come and ask, doctor, will LDL reduction in statin because a counter effect? Because statins always affect testosterone. We know cholesterol, pregnenolone, progesterone, 17-hydroxyprogesterone, androsterone, and testosterone. That's a pathway of testosterone. But you take statin also, testosterone level comes down by 1% only, where your abdominal obesity, your insulin resistance itself can reduce testosterone by more than 30%. So just understand the concept. ED is no longer erectile dysfunction, it is endothelial dysfunction. The biggest risk factor for ED is abdominal obesity or metabolic syndrome. Just like Rubin Shah was telling, never smoke, keep your abdominal less than 90 centimeter. And how does abdominal obesity lead to ED? Because when we used to study for MBBS, it was the thyroid gland, which was considered to be the largest endocrine gland in the body. Now we notice the adipose tissue, which is a waste energy depot, that is now considered to be the largest endocrine gland in the body. As your adipose tissue gets more and more bulkier, your insulin resistance type, human necrosis factor alpha, interleukin 6 and resistin increases. This kills the penile endothelium. So that's why abdominal obesity. Now I have 3 more minutes, or give me 5 minutes. It will be good for you only. So ultimately, so this is the basic mantra, because the concept without knowing nothing, because my time was 15 minutes, anything is okay for me. So understand this, the basic concept. Each gram of HbA1c more than 6 points. This is the famous slide which is present in all the diabetic conference by all the famous doctors. So each gram of HbA1c above 6.5, each millimeter of mercury above 130 by 80, each milligram of LDL cholesterol above 70, each puff of cigarette you smoke first occludes the narrowest artery in the body, penile artery, which is the diameter of 2 millimeter. Your coronary has a diameter of 3 to 4, your carotid has a diameter of 5 to 7, and your femoral artery has a diameter of 7 to 8 millimeter. Whereas your penile artery is the smallest artery where you can't put a stent, whereas you can put a stent in your coronary, carotid, and femoral artery. There you can take treatment only to prevent an endocrine. Just like I was again telling, you are building, and I can suppose whatever I require 3 minutes. So basically understand. So suppose you are having a whatever. This is the most important thing, because man can conquer oceans and man can conquer whatever continents, but ultimately you have a wife or any female who demands sex and you are not able to deliver that, you are finished. That's the same fate with Napoleon. Napoleon conquered whole world. We saw the movie, whole world, but ultimately Napoleon's wife was going with multiple corpses, and Napoleon every time was coming from Egypt, Austria, Vienna, everywhere, back to France just to look out whether Josephine with someone else, or he used to come for surprise taking. That 2 hours of travel in horseback from Russia and to check Josephine, because ultimately when Napoleon died, many people thought that Napoleon had a minuscule testis and a gynecomastia. That's why Reader's Digest and all the articles say that no one has seen Napoleon or Tipu Sultan wearing the whatever chest in an open field. So many people think that Napoleon was a Klinefelter. Actually, Napoleon had one hair only. Napoleon Bonaparte too, he died at 10 years because of measles something that time. But many other people think that he may not be a Klinefelter mosaic, because Klinefelter people are more voracious. They want to conquer other things because they are sexually always infantile. That performance is poor. Some people think that maybe in Saint Helena he was poisoned with arsenic, and arsenic would have caused a gynecomastia and testicle failure. failure. So whatever be it, understand prevention of ED is the most important thing, and men always miss the hormone. That is why what is the routine checking in a guy with an erectile dysfunction? Suppose you and me above 40 years are having some sort of penile dysfunction. You are thinking that the rigidity is not that good as before, or the penile rigidity you are not able to sustain for more than 15 minutes, or your ejaculation is getting much more faster. What are the routine tests? FSH, LH, testoprolactin, T3, T4, TSH, lipid profile, LFT, RFT, HbA1c, PSA age more than 40. Among the most important is testosterone. Understand which sentence I am telling. Because females have a wonderful thing that is known as a menstrual cycle. Suppose my wife is 42 years, she misses her menses for 3 months. What should she do? She will go to a gynecologist will do a UPT or an ultrasound for a PCOD or an FSH, prolactin, TSH for a premature menopause, hyperprolactinemia or a hypothyroidism. Suppose a 45-year-old guy is not able to have an adequate erection with his partner or not able to sustain, what will he do? First, he will not do anything. He will not go to any doctor. He will attribute to the stress he is having, smoking, alcohol, sugar, BP, cholesterol, BP, cholesterol, uterus of the wife that is being removed, or children who are studying in MBBS, or tell the glorious during my 35 years I enjoyed that, 40 years during my MD I went to Pattaya, I went to Vietnam. What is there? Your time to enjoy is when you have money, when your children are grown up, and you have enough money, that's the time to enjoy. So that is why your time to enjoy is 55, 60, 70. There is no age for sexual barrier, because ultimately sex should be safe sex. But people want to enjoy. Bill Clinton had a relation with Monica Lewinsky when Bill Clinton was 66 years because he had a good thing. So ultimately it was working. So many times, many very VIP politicians sometimes come to me in Kerala and tell, his wife tells, previously he was a big problematic guy. Now he's very gentleman. He's a family man, totally looks after the family. So I know that what family, now he is not having, now nothing is working for him. Sugar, BP, cholesterol, I know. He comes and tells me personally, no, nothing is on ex-minister, ex-deputy GM, whatever. Nothing is working, sugar for 20 years. So he's gentleman with children, grandchildren like that. Otherwise, whatever people cannot walk in front of him. So that is why sex always you have to continue, and testosterone replacement. That's why whenever a guy thinks that his sexual performance is coming down, always check the testosterone, and testosterone replacement can be safely given in men till the age of 65 years. But before doing that, always go to an endo, just do a total testosterone and PSA, PCV. If PSA, PCV is under control, give testosterone. And this is the 3-line therapy. Suppose a guy at the age of 45 years, just understand the point, 15 years of diabetes, just like a doctor nephrologist I saw 2 days back, 15 years of diabetes, 45 years with abdominal obesity, already underwent angioplasty, comes with an ED. His testosterone is normal, thyroid is normal, LDL is keeping less than 55, no NASH, HbA1c 6.2, PSA normal, still the penis is not working. Then the first option is giving him a sildenafil, tadalafil, vadinafil. He's already taking a Viagra 100 milligram for more than 6 months. First 3 months it's worked, now it is not at all working. So he's telling that Viagra is not good, doctor. I went to Dubai, bought Cialis, tadalafil from another brand. That is also not going to work, because Cialis hardly works in a patient where sildenafil doesn't work. If you have PDE5 inhibitor, sildenafil, tadalafil, vadinafil doesn't work, then the second option is an intracavernosal injection. That was telling alprostadil. Look at the last thing and then finish. This is the thing that every doctor or you and me should know. This is known as a penile processes. This shows that there is never ending for sex, because first line therapy fails. Many people are hesitant to go for injection, second line therapy. But second line therapy, it's not a therapy. Every time you go to your partner, you can take an intracavernosal injection, go with a pain priapism. That's not a possible option. It's an option for a person who wants an intercourse once in 2 months or 3 months. A wife demands sex every other day, you can't go for a penile injection. For them, best option is nothing but a penile process. Two types of process: inflatable processes, non-inflatable process. It is just like a silicone breast in a lady. Inflatable is you are putting a bladder that is into your two corpora cavernosa. A fluid filled sac is there. There's a switch on and switch off button. You switch it on, the fluid goes in, you have an erection. You switch it off, the fluid goes off, and your penis comes in the flaccid state. How do you think that?
We are running short of time.
So this is the last option. Yeah, it's the last slide.
Yes.
First I told you PDE5 inhibitor. Second is intracavernosal alprostadil. Third is always this is the penile process. From this is the last thing. Why did I tell about sex? It is an endocrinology for me. It's just like testosterone. It is my area is testosterone metabolic syndrome, making you aware that erectile dysfunction is no longer impotency. Erectile dysfunction is endocrine dysfunction. Prevention of ED is important. But once ED occurs, don't think that testosterone is the sole treatment. Testosterone is low treatment. If testosterone is not low, if your TMD is normal, go for a PDE5. That is not working, go for an intracavernosal. If that is not working, go for a penile process. If you don't want sex, leave it. If you want sex, you have options till the age of 70, 80 or 90. That's the thing of sexual dysfunction and metabolic syndrome. Thank you.
Thank you very much, Dr.
Thank you so much, sir. And as Dr. Bobby sir said, I could see the whole hall is full because of the sex education. And I think I remember the late Dr. O.P. Kapoor sir. He always used to say that, whenever a patient comes in my clinic, if I want to see whether the patient will have a heart disease in future or not, I tell the patient to stand up and tell him, छोटा भाई दिखता है क्या? अगर छोटा भाई नहीं दिखता है मतलब हार्ट अटैक आने वाला है. द वे सर सेड कि if the penile artery is blocked, definitely you can get a cardiac event in the future. So without much delay, I will introduce myself the session today. And my name is Dr. Pinkesh Rajput. I'm from Mumbai. I'm running my 3 clinics at Sion, Mahim and Chembur. And today I'm introducing the next 2 chairpersons with me. Dr. Surendra Gupta, senior physician and diabetologist. Dr. Deepak Das, please come on the stage. Associate Professor and Diabetologist, SRMS Institute of Medical Sciences, Bareilly. And let's see what is the topic for today. Last 3 topics. What is the priority of controlling an individualized treatment? So, whether it should be glucose or something else. To start with, we have our first speaker, Dr. Alka Gandhi Madam from Mumbai. He has a huge introduction list, but I will sum up with a small thing. That is, she's the founder of Ayushi Diabetes Clinic, Scope certified obesity consultant, diabetologist at Namaha Hospital, speaker and faculty at multiple conferences. She has conducted various public awareness campaigns, published articles, and committee member for challenges in diabetes. And she is an active member of ZAP, Kids, Road, Hope initiatives, and she has interest in GDM and diabetes. Thank you so much, ma'am. Over to you.
Thank you, Pinkesh, for the kind words of introduction. And good evening, everybody. Dr. Bansi Sabu and Team Diabetes India for invite. And after a very interesting session, we still have one more important talk, which is what should be priority in managing diabetes. And my concern is glucose. So I'm going to explain why glucose should be your priority in managing diabetes. So we've understood that diabetes is a major epidemic and it affects 537 million adults all over the world. It has a devastating health consequences, reduces the life expectancy by 5 to 20 years, increases the risk of other organ damages, and overall it costs a lot of economic cost. 35% of cost from loss of productivity is because of diabetes. So diabetes is a big burden to the nation. Now, to understand what is diabetes, I'm sure all of you don't need the introduction, but I'm telling this because to understand the importance of glucose. So, how is ADA defining diabetes? It is a group of metabolic disorder, carbohydrate metabolism, in which glucose is both underutilized as an energy source and overproduced due to inappropriate gluconeogenesis and glycogenolysis, resulting in hyperglycemia. So, it is a glucose fault which is leading to diabetes, right? Again, the diagnostic criteria, what it involves, it is the blood glucose levels. That is A1C more than 6.5, fasting more than 126, and postprandial more than 120. So these are the diagnostic criteria. Again, what it has, glucose values. Now, there are various types of diabetes: type 1, type 2, gestational diabetes, and other diabetes. Again, the classification has evolved over years now, trying to maintain the balance between insulin deficiency and insulin resistance. But overall, it is the glucose levels which are important, especially if you see managing type 1 as well as gestational diabetes. The most important factor you need to control is glucose. Now, why we want to control blood glucose levels is because of its complication, that is acute as well as chronic complications. So the acute complications are hyperglycemia symptoms, or there may be DK or HHNS or hypoglycemia. So in both the cases, of course, it requires an urgent management, and in that case, you have to control glucose whether it is hypo or hyper. The other problem is the chronic complications. It can be microvascular complications or macrovascular complications. And in order to prevent that, what is needed is again glucose control. So, how does glucose affect this? Basically, there are cellular damage mechanisms, formation of advanced glycation end products, increasing in reactive oxidation ROS, PKC activation. Again, there are because of this cellular damage, pathophysiological effects are seen. basically it is endothelial dysfunction and inflammation which happens because of hyperglycemia, and there may be impaired cellular repair mechanism. So all this, that is glycemic variability, whether it is hyperglycemia or hypoglycemia, will lead to oxidative stress, epigenetic changes and inflammatory cytokines. In hypoglycemia also, patient may have platelet activation dysfunction as well as inflammatory cytokines. So both this will lead to endothelial dysfunction and damage, and therefore there will be micro as well as macrovascular complications. So when we are seeing diabetes complication, cardiovascular disease is one part, but there are microvascular complications like foot neuropathy, nephropathy, retinopathy, also the skin conditions, there is gastroparesis, there are dental problems. So in all these problems also, the most important factor which we need to control is blood glucose levels. Again, when we see patients with diabetes, what are we advising? So there is a frequent blood glucose monitoring which is needed. Why? Because it detects the glycemic variability. Sorry, it detects the glycemic variability and the hypoglycemia. It gives us information about the treatment changes and the effect of food intake as well as physical activity. So ultimately, even the long-term trials, they have shown that 1% reduction in A1C is very clinically relevant. The UKPDS have shown that each 1% reduction causes 37% risk reduction in microvascular complications and 14% risk reduction in MI. Again, the advance have shown that for difference of 0.8%, there is 14% relative risk reduction in microvascular events. So overall, all the trials have shown 1% A1C has good improvement in micro as well as macrovascular event. Again, the intensive control is significantly associated with decreased risk of cardiovascular event, and this effect is more relevant in patients with shorter duration of diabetes, that is less than 10 years, and no pre-existing cardiovascular disease. Evidence have shown that acute hyperglycemia, such as achieved after meal or during glucose variability and hypoglycemia, could contribute to legacy effect on some pathways related to the development of diabetic complications. So if the patient is delayed in achieving an A1C target, even if a newly diagnosed patient, if there is a time wasted in achieving a good glycemic control, there is increased risk of developing CV disease. So it is important to hit early, hit hard. The legacy effect, the metabolic memory is what we all know, and this is various studies like DCCT as well as EDIC have shown how intensive therapy compared to conventional therapy helps in reducing the microvascular complications. Again, they have shown that this intensive treatment, if we start early, the effect persists later on also, that is the metabolic memory, as we all know. So it is very important to understand that hit early, hit hard is how it has started over the years. We are managing diabetes from so many years. The question of other parameters arise now in last 2 decades because of newer drugs, but glucose remains the mainstay because it is there since so many years now. What does ADA 2025 recommend when you are saying adhering to glycemic goals? Again, the ADA goals are A1C less than 7, fasting between 80 to 130, and postprandial less than 180. So these are again the goals given by ADA for diabetic patients. So when we are managing diabetes patient, of course, this is our priority to get them to this. The glycemic assessment, as we discussed earlier, you can monitor the A1C or you can have a CGM. The what they recommend is time in range is what we want. Of course, along with that, we want to avoid hypo as well as hyperglycemia. And I'm trying to run fast so that the time can be covered up because of the plenary sessions which will be starting soon. So again, the ADA has given an individualized glycemic goal criteria. So when we are managing patients with diabetes, whether the duration of disease, the risk of hypoglycemia, the other diseases that are present, and the pharmacotherapy with cardiovascular, kidney, weight, and other benefits. So all this is what we have to consider and keep the goal accordingly. You may keep it less stringent depending on the individualization. Again, this is an 88 guideline, and it recommends that glycemic control is one part. Depending on patients having CV risk, you can give importance to the drugs which are glucose lowering agents but will have a beneficial effect on the metabolic parameters and help in preventing or reducing ASCVD, CKD as well as heart failure. So again, I would say the same thing. Even if the patient is admitted in hospitalized patient, persistent hyperglycemia, where it is sugar levels are more than 180, you have a goal of 40 to 80. Again, in patient with diabetes, the goal is blood glucose levels. So I would just say that individualized glycemic criteria, minimize hypoglycemia, hit early, hit hard, will have a short term as well as long term benefits to prevent the complications. So, if we see the glycemic control, it has various aspects. Early benefit, as you can see, good glycemic control reduces the mortality. It also emphasizes on targeting the overall cardiorenal risk management. Again, importance of multifactorial management has to be taken in consideration. So, I would like to end by saying the glycemic control should remain the central early therapeutic goal for patients with type 2 diabetes. I would say all diabetic patients implement multifactorial management and multidisciplinary approach, regular reviews, patient empowerment, and personalized interventions tailored to these disease heterogeneity is important. Thank you.
Thank you very much for completing session before time. You are already running short of time. If at all there are any question you may ask, then we go to the second speaker, Dr. Piyush Desai.
Yeah.
Yeah, he is from the Surat, a consultant biologist and endocrinologist. Has done his postgraduate diploma in endocrinology from University of South Wales, UK. Recipient of the award for excellence in diabetes care by RSSDI in 2019. He has so many honors on his name, and without wasting much time, I straightaway offer mic to Dr. Piyush Desai.
Yeah, thank you.
Yes, thank you.
So from Monday to 2020 and 2022 to 2010, and I think good glycemic already saved 1 minute. So now next point in diabetes is obesity, and it is a neglected thing for years together. If and it's not a new concept. In 2011, glucocentric approach and adipocentric approach were described, but at that time the problem was there was controversial results of many anti-obesity medicine was there. We were having very few agent, and we were not having long-term data with that. Otherwise, to treat pathology, the right approach is to treat pathology, and that is very true for most of our type 2 diabetic patient. Because type 1 GDM, yes, we have to be glucocentric, but at the same time, in type 2 diabetes and with severe risk, it is obesity which is playing a role, and which is very nicely described by our own Dr. Professor Yajnik when he was doing this thin fat Indian study, and we all are looking thin, but still we are obese. And that's why the concept of obesity with diabetes, it turns out to be diabesity. And diabesity is nothing but combination of this deadly duo, which is causing almost half of the patients suffering with obesity and diabetes both, and numbers are increasing day by day because of change in our lifestyle. Why obesity matters in diabetology? Because it is common, because it is associated with CVD. My next speaker is going to put emphasis on this part, and that's why we have to treat obesity, because it is modifiable risk factor. That is most important thing, and it is white adipose tissue which is giving rise to multiple other cytokines and inflammatory markers, which increases cardiometabolic syndrome. That is the risk factor, and that is mainly because of glucotoxicity, lipotoxicity, and inflammation, which is secondary to insulin resistance, which leads to change in the translation of mitochondrial pathway, which leads to multiple pathophysiology, which can be described as hypertension, coronary artery disease, hyperlipidemia, and along with that, adiposopathy may leads to osteoarthritis, non-alcoholic steatohepatitis, obstructive sleep apnea, and macro as well as microvascular complication of diabetes also. And there is nothing like sudden heart attack, which we are listening, which we are reading so commonly. It is central adiposity, lack of physical activity, genes, and over the top, this multiple inflammatory markers in form of decrease in adiponectin level, increase in leptin level, RO2 activation, RAS activation, TNF alpha, interleukin 6 and CRP elevation, and increase in the free fatty acid, which leads to metabolic syndrome and CVD. So what should be our prime goal to treat type 2 diabetes? Yes, glucocentric approach, as it is very important once patient is diabetic. But can we do it before? When patient is pre-diabetic, when patient is obese, it's an upstream approach, upstream intervention, and for that patient has to lose weight. If patient loses weight by 5 to 10%, there is better type 2 diabetes management. Fatty liver improves, PCOS improves, dyslipidemia improves. For reversal, for remission, actually, and for real change in the fatty acid, fatty liver, it should be 10 to 15% of the weight loss. And more than 15% actually leads to type 2 diabetes remission, as well as CV mortality, as well as reducing preserved ejection fraction heart failure. So target of weight loss 15 milligram is new HbA1c target of 7. What we are talking about. So if we are glucocentric, it is less than 7 HbA1c. Similarly, for weight loss, if we can achieve more than 10, and if possibly more than 15%, you can see number of studies with us which has shown excellent diabetes remission or decrease in complication with multiple things. This is continuum. When patient is diabetic or patient develops various complications, it starts before it, when patient is in hyperinsulinic phase. So can we have impact when patient is pre-diabetic? We have diabetes prevention program where lifestyle modification was compared to metformin to compared to placebo, and we found that not even metformin, it is lifestyle modification and persistent weight loss which has shown excellent benefit of 58% reduction in type 2 diabetes occurrence. Similarly, once patient is diabetic, can we remit it for a while without medicine or with very few medicine or like insulin sensitizer? Yes, it is also possible. We have look ahead study where it strict intervention in form of diet and exercise was done in comparison to placebo, and you can see there is excellent weight loss. The only problem in look ahead study was it was difficult to maintain, it was difficult to achieve that weight loss for longer period of time because patient starts regaining. Then comes direct study. Direct study was done again with very low carb diet and change in the fat, targeting 15% weight loss. And you can see that with 15 kg or more than 10 kg weight loss, there was excellent ratio of diabetic remission, and that was persistent for 1 to 2 years. That is something excellent and which has shown, which has changed our treatment pathway. And when we are talking about micro and macrovascular complication, we have some data from look ahead study that more than 10% of the weight loss is also reducing CV mortality as well as other complications of diabetes. So our approach should start with obesity before patient develops frank diabetes, and for that we have diet, exercise, behavioral therapy, we have pharmacological therapy, and obviously with morbid obesity it is bariatric surgery. So BMI 25, lifestyle changes is enough. BMI 27, it is you have to consider pharmacotherapy, more than 30 pharmacotherapy, and after that you have to consider bariatric surgery for such type of patient. As far as dietary pointer is concerned, all diet are good ultimately if person restrict total calorie and the calorie deficit is more than 500, then it is helpful, and whatever diet patient is convenient to is patient has to continue for longer period of time. Along with that, lifestyle modification is having restriction because as look at study has suggested, over the 2, 3, 4 years patient starts regaining because patients are not actually maintaining their lifestyle. Many anti-obesity medicine has limited efficacy like phentermine, topiramate, naltrexone, bupropion, and even we have liraglutide, which was having only 5 to 7% of weight loss, and few were withdrawn from the market also. Now we have GLP-1 RAs like semaglutide. We have dual GLP-GIP combination, that is tirzepatide. Even retatrutide is coming. It is in clinical trial. And SGLT2 inhibitor. These are disease-modifying agent rather than an anti-diabetic agent. And with liraglutide, we had good weight loss, but now with sema and tirzepatide, we are aiming for more than 15% of weight loss, which exactly we are looking for. And you can see the data of step 1 to step 8 study with semaglutide. Patients are losing more than 10% of body weight loss. 2.4 milligram semaglutide, the higher dose, is even better. That is in step 10 trial, which has shown almost 15% of weight loss. Similar data with SERPA study with tirzepatide, 13% of weight loss, which is fine. And retatrutide, actually we are aiming with 20 to 22 percentage of body weight loss with 50% reduction in liver. So now we have agent to substantiate that, and there is one data of empagliflozin and liraglutide combination which actually reduces CV risk also. Along with that, if patient is morbidly obese, obesity of BMI more than 30 with comorbidity, you can have option of bariatric surgery also. And with bariatric surgery, you can see in comparison to medical therapy, it is having even better result as far as diabetes remission is concerned, and lesser patient were having microvascular complication after this. Except cerebrovascular disease, in all part you can see all cause mortality, heart failure, CAD, atrial fibrillation and nephropathy was improved after the risk was improved after bariatric surgery in comparison to patient who opted for medical therapy. There is another data where 90% of the patient were having diabetes remission. These are 21 studies from Asia after bariatric surgery. So weight reduction is very important. And when we are coming across type 2 diabetes, or maybe I say before type 2 diabetes in a pre-diabetic phase, if we target weight, you are going to target HbA1c. And this should be our new target. And for that, recommendations are also now looking for that you should uh, take the agent which causes weight loss if possible and if it is tolerated, and you should prefer to use that obesitogenic agent later in diabetes practice. So I think weight is very important part and we should always focus for that. Thank you.
Thank you. Now I call for the third speaker, Dr. Parikshit Goswami from Himmatnagar. He is MD DFID, postgraduate diploma in endocrine from South Wales. He is consultant diabetologist, Ayush Clinic, Himmatnagar for more than 14 years. He have a book chapter, International IDF, many poster presentation at National Conference. He is joint secretary of our SSTI
Thank you.
Gujarat chapter and member of various societies. I invite Parikshit Goswami to speak on the topic cardiovascular factors.
Thank you. Thank you very much, Chairperson, for a kind introduction. My two previous speakers had alluded regarding the glycemic control and the weight management. Now, I have a question for all of you, that what drives mortality in diabetes? Is it a blood sugar? Is it a weight? And we have been taught, and we are looking every time, day in, day out in our practice, the macrovascular complication and the microvascular complication. So we all are afraid. Not only we are afraid, but our patients are also afraid regarding these complications. This is very important slide to understand cardiovascular death in India. What we are talking about India, 1 out of 4 deaths due to cardiovascular disorder. Any patient come to you with a blood sugar of 250, maybe the patient might be worried, you might be little worried, but at that point of time, nothing will happen. So what you need to look into it, what is the vascular issue that particular patient have? Because that drives the mortality. The CKD and heart failure are the commonest manifestation in people with type 2 diabetes. Then subsequently stroke, myocardial infarction and peripheral artery disease. Again, if you carefully look, a vascular problem underneath all this complication. It's a vascular complication, whether it is CKD, heart failure, stroke, myocardial infarction, or the PADs. There's a huge prevalence of chronic kidney disease in our setup. So 2 lakhs patients on dialysis and 4,950 dialysis center across India. So large number of the patient can be prevented. But how? If you prevent the vascular complication, that's what the microvascular complication, not the weight and not the glycemic burden. As we all know, the cardiovascular risk increases early in the natural history of type 2 diabetes. So even before the patient have high blood sugar, as we all know that, the macrovascular risk begins early in the stage pre-diabetes. This important study, the progression of early subclinical atherosclerosis PISA study. And this study shows important aspects. There's a linear correlation between blood sugar level, that is here HbA1c, and the patient percentage having a subclinical atherosclerosis at the level of carotid arteries, iliac and femoral arteries, and they have looked at coronary artery calcium score also. So every bit of rise in HbA1c level, you will have atherosclerosis. So again, a vascular issue. Risk for cardiovascular events start rising before onset of diabetes. This is again a nurse health study. 3.6-fold increase in risk of myocardial infarction and stroke before type 2 diabetes onset. These are the marker for subclinical heart failure, the cardiac troponin T, CRP, NT-proBNP, LV ejection fraction, global longitudinal strain, E by E prime ratio. Even a pre-diabetes stage, you have a raised marker for subclinical heart failure. And what we had learned from the ACCORD and advanced data, the intensive glycemic control not effective, but on the contrary, it increases the risk. So sugar control beyond certain point is not beneficial. Again, newly type 2 diagnosis, type 2 diabetes patients have a multiple risk factors. And we are talking and we will be talking in future also regarding these landmark trials, LEADER, EMPOWER-X, REWIND, SUSTAIN, CANVAS and DECLARE. But if you carefully look at A1C data actually, there is no robust A1C reductions were reported actually. Okay, although the baseline HbA1c were also not high, but not a robust HbA1c reductions were reported. So that's the message is that even if you are not achieving a excellent glycemic control, you are preventing cardiovascular hard endpoints. You are reducing the cardiovascular hard endpoints. And these are the data set. Most of the SGLT2 inhibitors have a positive outcome data for a MACE, CV death, hospitalization for the heart failure, hard renal endpoints, albuminuria, and all-cause mortality. And a few points were missed by GLP-1 in terms of hospitalization for the heart failure and the hard renal endpoints. Now, this slide is for my first speaker, Dr. Alkaben. Despite multiple options we have, 1/4 of the patient achieve the good glycemic control. And my first slide was that in India, 1 out of 4 deaths are attributable to cardiovascular disorder. So, do you think so vascular problem is bigger than the glycemic problem? Now, regarding the weight, what happens with the weight loss actually? Okay. Dr. Piyush Bhai had shown an important data set from the Look Ahead trial. We know the DPP trial also, diabetes prevention program also. We know previously very well about the surgical treatment, now the pharmacotherapy. Whatever the treatment you take, okay, at some point of the time, there is a plateau. Okay. And if that person either not following the diet and exercise, then the weight will be regained. Now, the surgical aspects. Whatever the surgery you have done, whether it's RUX and bypass or sleeve gastrectomy or many other, again the weight loss will be plateau and again there will be a regain. And same with the pharmacotherapy, whether it is step data or the surpass data or whatever the data you take. As soon as you stop taking the drugs, there will be weight regain happen. So you people will tell, yeah, okay, once you stop the treatment, obviously will regain the weight. But what will happen to the vascular issue actually? Yesterday, in one of the plenary session, I forget the doctor name, was a very senior doctor, and what he had shown in the last slide. Once you lose the weight, actually, of course you will be benefited in terms of vascular protection. That's what I'm talking, and you also know. But once you regain the weight, your vascular issue will go much higher. Okay, and he proposes, it's not proven, but he proposes the therapy that some some pro-inflammations happen, and the inflammation will increase substantially once the patient gain the weight. So again the point is to prevent the vascular complication, and we have a wonderful data. I'm not going to detail. You all know that data. So vascular is the mantra to help our patients. And most of the guidelines, now this is ADA ESD consensus statement that ASCVD, risk factor, heart failure, and the CKD. That is the target. And afterwards, you have to think about the glycemic management and the weight management. So vascular protection is the most important aspects of managing type 2 diabetes. Thank you very much.
I think this must be the only session where all the speakers go give their lectures before time. So also
Big round of applause.
your eager. If there are any questions you may have, but as such, I would agree to Dr. Parikshit. Basically, ultimately, it is vascular protection what we need, other than sugar or weight or so. Supposingly, you go to Mahakumbh and don't have that teeth, then there is no point. You won't be able to cleanse your sins. And you have to have that teeth. So ultimately, vascular protection is that like that deep in Mahakumbh. So I would agree to Parikshit. Of course, all the three speakers they did well. If at all there are any questions you may ask.
There are
Yeah.
According to that, weight loss is not from only fats, it's from the protein mass, muscle mass. And it is once there is an effort increase in the weight of the throat, it comes kind of cases. And then muscle mass doesn't get weight.
Yeah, that is very important thing. And that's why Dr. Pariksit very nicely pointed out one thing, that it is fine to lose weight, but when you regain, it is fat mass which is regaining, and that is causing more severe risk. And that's why no therapy, if you see the guideline, BMI more than 25 or 35, no therapy or surgery should be without lifestyle modification, which includes exercise, and exercise is resistant exercise. So that is very important thing.
आप करना नहीं आप करना ही क्यों सर मैक्सिमम HbA1c reduction is by lifestyle modification 1.5%.